Okay, so Dr. Sutter asked me to present to you the new Facebook group interpretation of the T-scan, the gum chewing study that John Radke and I published in 2016. That's a landmark paper because it's the first paper in the history of dental medicine that shows that you can render an occlusal treatment and it will improve human chewing. There's no paper other than this one in the entire annals of dental literature that shows that you can improve human chewing. So I'm going to present that to you, and then you guys can interpret it on the new interpretation site. Okay, so this was the first time that I presented this paper was at the European Association for Cranio-Maxillofacial Surgery. It was in London, and it was done just after the paper came out. And here's the citation down here if you're interested in seeing the citation. Along with this study, which showed you can improve human chewing, there are a number of DTR, ICHD research publications that are modern that are really show the power of disclusion time reduction. This one, the 2016 one is what I'm going to show you. In 2019, we did a smoothness of chewing study, which showed that not only did the chewing improve, but the mechanics, the motion quality also improved. We've been able to show how you can treat cold sensitivity without covering the roots, without doing medicaments, without doing any kind of bonding. And that has been shown to improve cold tooth sensitivity. We had 100 and something, 136 patients, I think, in that study. And we had marked improvements in cold tooth sensitivity. We've also done a study that was published in 2018 that showed that you can reduce the PIPER risk for a patient by 2 levels by treating them with a DTR and ICAGD. And you can safely treat PIPER classification 4A or less using DTR. So that's certainly a valuable treatment in that it improves disc pathology fairly predictably. We've also shown that we can improve emotional depression, and this of course counters the psychosocial belief system that TMJ is an emotional problem. It's not a physical problem. Of course, we know that's not the case at all. Occlusion is a major player in causing TMD, and we've been showing that for years with the DTR and ICAGD, many publications, but we never treated emotional depression until this paper where we actually used the Beck Depression Inventory, and we reduced the depression in 80 patients, which started out, most of them were moderately to severely depressed, and that they had chronic pain. They were living in chronic pain, and within 3 months, only 2 of the subjects of the 80 were borderline depressed. And recently, we just published in April a randomized controlled DTR study. Of course, the literature has been always saying you need randomized controlled trials, and if you don't have randomized controlled trials, then you're not actually doing real research. Of course, that's just criticism that's invalid, but certainly something that pervades the dental literature. Well, we just completed one, and the control group, which was 50 subjects, and the treated group was 100 subjects, the control group had no placebo effect. And that's really important. It showed the power of the DTR process, and of course the control group didn't get better when they didn't get the real treatment. So that's available for you to read now. All of those papers will show you the power of the DTR process. Before I show you the gum chewing study, I just want to illustrate that there's this belief system that if you have canine guidance, you have good disclusion. Well, that's only true if the guidance is extremely steep. In most patients who have good guidance, they don't disclude the posterior teeth if the person moves a small distance. And this is the functional zone. People do not slide out to the tip of their canine. When they chew, clench, grind, swallow, they do it right around the central fossa. So if you want to see if the person is not discluded, just have them move a short distance. Here you can see the patient's moved about 1/4 of her incisal edge, and she's not discluded. And the reason this happens is that the condyle sits in a soft tissue disc, and so the posterior aspect of mandibular motion is squishy. And so the condyle doesn't lift the teeth apart posteriorly, and the guidance isn't steep enough to do it. And you see that on the left side as well. So here you see the group function that's present, the premolars are involved in the guidance, and you can't see the lingual. The Lingual is never visible from the buccal. So when you look at a picture of someone sliding to the right or left and you see space between there, you cannot see the lingual. You have no idea about the early lingual to lingual contacts. That's the outer aspect of the palatal cusp rubbing against the inner aspect of the lower lingual cusp. So in the gum chewing study, we used the electronathography hardware from BioResearch, which is the jaw tracking technology. You place a magnet on the patient's lower front teeth, and you then have the patient chew 20 cycles of chewing unilaterally with gum, only on the left side, and you record only going to the left. Then you move the gum to the right, and you redo the chewing unilaterally. And the software records it in 3 dimensions, frontally, horizontally, and sagittally. And then it makes a composite of the chewing stroke. We actually had the subjects do 20 chews to the right, 20 chews to the left, and then they redid the chewing, 20 to the either side again. And then a composite was made. So we were using 40 chews to make the composite. So here's this patient's chewing composite. This is the average chewing pattern, the full chewing stroke. They open to the left, they close to the right. They basically have about 17 millimeters of opening, and they have pretty normal shape. But it's interesting when you look at it and break it down in the different views. The norm is this black ellipse chewing to the left, and you see the patient is more chewing along the midline. And this is not normal. So you see the patient is actually not able to chew within the norm. Sagittally, the patient should be chewing under their nose, and instead this patient is chewing out in front of their nose. And horizontally, this is the most interesting one. They should be chewing out to the left and then back to the right. And here you see the patient is really chewing out to the right and then back to the left, which is completely backwards. So this is less than ideal. And but this is a dysfunctional chewing pattern. Then the patient underwent the ICAGD coronoplasty, so long and short disclusion time. So here you see the patient has canine guidance, but they do not disclude. So how long does it take to make that line, or to make that line, or to make this line, or to make that line? Well, the disclusion time is the summation of all of those time-based movements across the surface of teeth. Here's the lingual to lingual ones I was talking about. You see they're present here. And so this is the patient's left side, this is the patient's right side, and here you see again, patients, how long does it take to make this in the balancing movement? There's lingual to lingual contact, buccal to buccal contact, buccal to buccal. How long does it take to make that line? How long does it take to make that line? That's what the T-scan can measure, and of course the muscle activity is recorded at the same time. And this is in the treatment process, and you see the contacts are beginning to line up. But there's still linear components to them. There's still flaws in this, like that, and like that, and like that, right there. And so just making the contacts look a certain way isn't adequate. The only way to know if the disclusion time is shortened adequately is to measure it with the T-scan. If you don't measure it, there's no way to know. Just making the contacts look a certain way is not adequate. And you'll be fooled a lot because the T-scan is very harsh. It doesn't show you what you want to see. It shows you the reality. So this disclusion time may not be short enough, and then we'd go back and refine it. So here's our patient. This is the patient moving to the left, and they bite down, hold their teeth together, slide to the left, and notice this is T-scan 8, that the posterior left, light blue, and the posterior right, light brown, are both involved in the excursion. And the anterior left, the dark blue, is not present. You don't see the dark blue line rising to the top of the graph. So this patient has both working and non-working side blockages, and this is their muscle firing pattern. Here they're waiting to bite. Here they begin to bite. They hold their teeth together between B and C, and here they slide to the left. And this is all mapped exactly to the T-scan. And you see there's very high excursive muscle firing taking place. Then we treat them. So this is all happening in the same day. They did the gum chewing. They underwent the DTR, EMG, ICAGD analysis, which you're seeing here, and then they go through the treatment. And here in the end of the day treatment, you see markedly less muscle activity and left excursion. But notice it's actually very hard to disclude the patient. There is still some group function contact there. And if you look carefully at the graph, the dark blue line does rise to the top of the graph now, But the light blue line is visible, meaning that there is posterior teeth in the way, and that's what you're seeing here. And as a result, it just shows you how difficult it is to actually disclude someone. So unless you measure it, you may not have a good result. And this is 4/10 of a second. That's the disclusion time afterwards. Then the patient goes home, comes back 7 days later, and redoes the 40 cycles of chewing. So this is the new composite, their average chewing pattern now 1 week post-treatment. And look at the chewing stroke. It's much wider, broader, taller. Subject gained 2 to 3 millimeters of vertical. Notice in chewing frontally now that the opening cycle is more within the ellipse. Oops, let me go back. It's more within the ellipse, and it's still a little right of center, but it's much more left of center than the pre-treatment condition, almost within the norm. Sagittally, the patient is chewing under their nose now, no longer out in front of their face, which you see here. And horizontally, you see the patient does open out to the left and come back. They go out and they come back. And so, there's a lot more normalcy here than there was here. And this is, again, after 7 days, without chewing instructions, without splints, without Botox, without chiropractors, without any kind of intervention. No chewing instructions, just having their disclusion time changed. Now, if we look at the statistics, because we use software, there's a lot of things you can measure. So we measured timings and velocities. So you can see this is for the entire group. The opening time went down, so the chewing speed went up. The closing time went down, so the chewing speed went up. The whole cycle time went down, and you can see that this is the tooth contact time that is less, which means the patient got in and out of their teeth faster, and the entire cycle time, which is here, also went down. And the p-values are dramatic. Anytime you have p less than 0.05, you're talking about 95% of the time some statistical change occurred. When you have multiple zeros, it means nearly 100% of the time for the group, the changes were significant. So this was the closing times. Now the velocities, if you look at the velocities, they went up. The maximum opening velocity went up from 73 to 84 milliseconds. The maximum closing velocity went up from 85 to 95, again, with dramatic p-values. The average opening velocity went up dramatically. You see it here. And the average closing velocity went up dramatically. And this, again, is for the entire group. And look at the p-values. This means nearly 100% of the time, the opening velocity went up. So the patients were chewing stronger, faster, taller, wider after 1 week just by having their disclusion time changed. Now, some of the interesting things that we saw were, for example, in this patient's right chewing, prior to treatment, she had 16 silent periods, 12 silent periods and 16 chewing cycles. The silent periods are where the muscle activity shuts off, the contractions are interrupted by noxious stimuli. Well, this would be the patient running into their teeth repeatedly in the chewing stroke. After treatment, that same patient in 16 cycles of chewing only had 1 silent period. So that's a dramatic improvement in the physiology of chewing. And if you look at the individual muscles, as they make each chewing stroke, you can see a lot of haphazard contraction cycling. So here you see some early contractions in one chewing stroke, in this chewing stroke, then you see some in the middle, then you see some late. So there's not harmony amongst the different chewing strokes. The muscles each muscle is contracting at different times instead of contracting uniformly. And you can see that in all 4 muscles of mastication in this subject when she chewed to the right. Here are some early ones, and here are some middle cycle ones, and here are some late contractions. After treatment, 7 days later, and you can see the dates, all of the chewing strokes were uniform. Look at the muscle activity. It's now one curve. No longer is it haphazard. And you see it in all 4 muscles. Well, those 2 different scenarios can be composited as well. And here you see it, the average chewing cycle. So pre-treatment, the average chewing cycle has slowdowns, stoppages, there's a weak amplitude, and very interesting thing, the end of chewing should occur after the maximum contraction because you want to be able to crush down on the food. And here you see the patient's maximum contraction occurred after the end of chewing, and then you have the the slowdown in chewing, and then the turning point where they start again. And you can see this is not ideal. Whereas after treatment, 1 week later, look at the amplitude increase, the smoothness increase in all the different muscles, and notice that the maximum clench or crush occurred before the end of chewing. And again, this occurred without any chewing training or without any adjunctive therapy, just by performing the disclusion time reduction. So, in conclusion, the average chewing patterns, shape, speed, consistency, muscular coordination, and vertical opening all dramatically improved in 1 week's time by performing disclusion time reduction without the patients wearing pre or post-treatment splints, orthotics, deprogrammers, or undergoing Botox, TENS, chirodontics, or having any kind of chewing instruction. So this was, again, a physiologic improvement that occurred from within the central nervous system. Now, if you're interested in seeing the randomized controlled disclusion time reduction study, this is the citation. So feel free to go there and read it. As I said, Advanced Dental Technologies is an open journal, so you can definitely just type in this link and you'll find type in this citation and you'll find it'll take you right to the article. Okay, so thank you for your time, and if you have any input or questions, you certainly can post them on the new site, Interpretation of the T-Scan, and thank you for your time and attention. I look forward to hearing your feedback.